My name is Robert Zeiser. I'm the director of the Division of Tumor Immunology at Freiburg University Hospital, Germany, and I will report today about the results from the REACH2 clinical trial, as well as some data on prospective things that will be investigated in future studies to better understand which patients respond to ruxolitinib and which ones do not. So the REACH2 trial is a randomized phase 3 trial evaluating the efficacy and safety of ruxolitinib as a best available therapy in patients with steroid-refractory acute graft-versus-host disease. In this trial, patients were randomized to receive either ruxolitinib or best available treatment, which included ATG, extracorporeal photophoresis, mesenchymal stroma cells, low-dose methotrexate, mycophenolate mofetil, everolimus, sirolimus, etanercept, or infliximab as BAT options. And until day 28, patients were treated with either ruxolitinib or BAT, and then evaluated for response rate on day 28, as well as a key secondary endpoint for durable overall response at day 56. The majority of those patients had severe graft-versus-host disease, grade 3 to 4, more than 60% in the BAT and ruxolitinib arm. The response rate on day 28 was significantly higher for ruxolitinib as compared to BAT. The overall response rate was 62% in the rux arm compared to 39% in the BAT arm. And the durable overall response at day 56 was significantly higher for ruxolitinib compared to BAT. Now, one can argue that the response in an open label phase 3 trial can be subjective and depends on the physician decision. But what is an objective, clear parameter is failure to treatment, which means that the patient had to receive additional immunosuppression or died or had a relapse, for example. And this failure-free survival was also significantly higher in the ruxolitinib arm as compared to the control arm. Safety was as expected. Patients who received ruxolitinib had higher grade 3 thrombocytopenia as compared to the BAT arm. Cytomegalovirus infection was not significantly higher. It's comparable in both groups. So the question that comes after this study that indicates that ruxolitinib is better than BAT is what is the overall survival of those patients, and is there at some point a significant difference in overall survival? And this will be tested at a longer follow-up and is expected by the end of 2020. Also, of course, we would like to know which patients benefit most from ruxolitinib and which patients fail ruxolitinib. And for that, there will be a biomarker evaluation study where reported biomarkers like ST2, REACH3, alpha, and others will be included and correlated with response rate. I think with that, we can say now that ruxolitinib is at this point the current standard for patients who have failed corticosteroids. And future studies have to evaluate if there is an advantage for patients to receive other drugs as a third-line therapy. This will be is an open question. And of course, also which patients need to be treated differently because a priori they are unlikely to respond to ruxolitinib. This will be the future research in this field. Thank you for listening.